Hi, I'm Dr. Derek Lee. I'm happy to introduce Dr. Baron Lonner, who is the Chief of Minimally Invasive Scoliosis Surgery at Mount Sinai Hospital. He's also a Professor of Orthopedic Surgery at Icahn School of Medicine. Welcome, Dr. Lonner.
Thank you. Great to be here with you, Derek. Dr. Lee.
Same thing is good.
Yes.
Question I have for you when I actually do these interviews is I like to get a little bit of a taste of what that person's like and where they come from. So I was wondering if you could talk a little bit about your influences in terms of your career, in terms of where you started, how you got interested in medicine, and how you became a spine surgeon.
Well, the way I got interested in medicine is I had a beloved grandmother who became ill when I was a young boy, and I watched her go through the maze of healthcare and the trials and tribulations of her disease. And I immediately was drawn to medicine and the treatment of patients, and I always come at it from a point of compassion and caring, and I find it fascinating as well. So with that, I continued to have in my mind from the time I was very young that I wanted to become a physician. And I was fortunate to be accepted into medical school right out of high school. So it was a 6-year medical program. So I was able to continue on my path. And while in medical school at Boston University, I was fortunate to be able to do research at Boston Children's Hospital with Dr. John Hall and Michael Millis. And Dr. Hall was one of the giants in the treatment of scoliosis. He was an innovator. He was truly a giant of a man. He was a kind and compassionate doctor, so he was a fantastic role model. And I did research at Boston Children's for almost 2 years in between my medical studies on congenital scoliosis. So, and then from there, I went on to do my residency in orthopedic surgery at Montefiore Medical Center and Albert Einstein College of Medicine. And there I met Dr. Hoppenfeld, Stanley Hoppenfeld, who recently passed. And Dr. Hoppenfeld was a big influence and it taught me the fundamentals of scoliosis treatment and surgery. And he was a prolific, he was an educator and a prolific writer of textbooks for orthopedics, some of which we still use today and are very important on anatomy and exposures for surgery. So, and Dr. Hoppenfeld then sent me off to the Hospital for Special Surgery, where I did my fellowship. And there I met, in addition to other surgeons, I met Dr. Boachi, who was my mentor there and has had a tremendous influence on me and taught me complex surgery and principles and techniques. And I remain friendly with Dr. Boachi, who is now in his birth home of Ghana, Africa, where he treats patients there to this day. So those are some of my influences. Early on, because of my research in congenital scoliosis, I had an interest, and then Dr. Hoppenfeld solidified and cemented my interest in caring for scoliosis patients. I really was drawn to the fact that we could take somebody for surgical patients, someone who has a significant, the word deformity, it's an honest sentiment for the young person or an adult who has lived with scoliosis their entire life, feels like they have a significant asymmetry of their body, and it's something that they may be self-conscious about. And with surgery, you can correct that and improve that. And it really has an impact, not just physically, but a psychological and emotional and social impact on the patients. And I've always been fascinated by that and appreciate that aspect of scoliosis treatment. And early on, almost 25 years ago, I've been at this for a while now, nearly 25 years ago, I realized that we could do this with less invasive approaches. We could do our procedures with less approaches that disrupted the muscle less, that was done through smaller incisions with less blood loss and more rapid recovery. And so I embarked on a journey to teach myself and to then apply for patient care thoracoscopic procedures. So we performed fusion operations through the side, through small portals, and placed screws and removed the discs in the spine and placed a solid metal rod and corrected curvatures. And we did a shorter fusion, so less levels of the spine were fused than if we were to do the same procedure for the same patient, but done from a posterior or back approach.
Mm-hmm.
So I did those procedures for 10 or 15 years or so, but then we found that, with the more modern instrumentation from the posterior approach, from the back approach, we could get our patients back to activity sooner. So I sort of migrated to that. And I'm sorry I did, because I think still to this day, my thoracoscopic fusion patients are amongst the happiest, even long-term following surgery. So
it's fascinating because was your thoracoscopic approach minimally invasive? Was it specifically for the anterior fusion approach that you developed that? Okay.
Yes. So for the thoracoscopic surgery was, in the chest for the thoracic curves, the rib portion of the spine. And we did develop that and improve the techniques in that area. And then we also did thoracolumbar curves, so curves lower into the lumbar spine. And for that, we would do the same types of approaches that I know we'll discuss today, both for thoracic and for thoracolumbar curves. We did small incisions for the thoracolumbar curve and were able to achieve excellent corrections, again, with shorter fusions than the posterior or the back counterpart of operation. And, I look and I try to follow my patients forever until I retire, and then someone else will take over. But patients come back, and I've seen some of the incisions for those lumbar curves, and they're much bigger than what we're doing today. So we're really, I think, doing a better job of keeping incisions smaller and then recovery faster. And the experience of surgery, I think, is easier when patients have smaller incisions and less trauma to their tissues, to their muscles and the skin, etc.
Dr. Lonner, I was wondering if we could talk a little bit about the minimally invasive thoracoscopic versus mini open in terms of the anterior approach. Can you talk about that a bit?
Sure, it'd be my pleasure, Derek. I have been, as I told you, I've been doing these approaches for 25 years. And when we were doing thoracoscopic fusions 25 years ago, we spent a lot of time being purist and only using ports. And I would do 5 or 6 ports. I would place 5 or 6 ports for our patients. We'd have the scope, we'd hold the retractor for the diaphragm and the lung, and we'd have the working ports to place our screws. If you added all those incisions up, you have a much longer incision, and there are many different approaches. So what I do now is I tend, and really a port is kind of like a smaller mini thoracotomy, because we're going into the chest and in any case. So my mini thoracotomy is about 2 ports long, and that's what I do. And then I do usually one other small port, which is a traditional thoracoscopic. And then there's a site for the chest tube where we put our scope in, and that's about 5 millimeters in length. So most of the surgeries we do through 2 or 3 ports, with one being slightly larger for mini thoracotomy, so we can get a lot more done. And I think that it adds up to about the same or less even, because I do fewer incisions. And so for the patients, I think the most important thing is we need to place the screws safely. We have to do it efficiently, because if the operation takes a real long time, the patient ends up with congestion in their downside lung, where they've been lying for hours on end. So the operation should be done efficiently and safely, and with little blood loss. And I think we do that very well through that approach.
Now, I've heard that some surgeons who do mature tethering or even immature, but they use ASC with the mini open, they
Yes.
like to do that just because there's more physical room to maneuver, and even for derotating spines, there's more leverage.
Right.
Can you address that?
Yeah, so I think there is some truth to that, and that's been helpful. Yesterday, I did an operation on a girl who's still growing, but she's slowing down, and she had, we did 2 mini thoracotomies because I placed 2 rows of screws. And you really can't do that through just a standard port. So we did 2 mini thoracotomies. They're very small incisions, really, and then a single small port above. And we got a double row of screws and a really nice correction. And she's a high-level volleyball player that's being sought out by Division I colleges, and she's not even in 9th grade yet. So we felt that it was important to give her extra cord, and for that we needed to do the thoracotomy. It also allows you to do disc releases when you feel that's important, and we derotate in every case, but I think it's mostly a function of getting 2 screws in.
Okay.
Is why we need that. But for even my standard cases with a single screw, we just find it to be a very efficient way, and the patients do really well with small incisions.
I was speaking to a few of the spine surgeons about the anterior approach versus the posterior fusion approach as
Yes.
well, and how it's kind of the anterior approach has kind of fallen out of favor for the last 10 to 15 years. But I was also speaking to Dr. Tony Herring,
Yes.
and he kind of anticipates that it's going to cycle around back to the anterior approach, which
Yes.
is kind of ironic because he's seen 40 decades or 4 decades of fusion surgery, and I guess it's what becomes old becomes new again in some cycles.
Well, I think we can learn from the past, and we can improve upon techniques that were once performed. And I think sometimes there are trends in healthcare and medicine and surgery that catch on for various reasons, because maybe the learning curve for surgeons was very long and hard for them to learn the techniques of thoracoscopic surgery. So it wasn't applicable to many surgeons for them to be able to offer to their patients safely and with surgery performed in an efficient way, so it doesn't take half a day or all day. And so I think that was one reason why thoracoscopic and anterior techniques fell by the wayside. And there were some surgeons who were really speaking against them because they felt that there would be an impact on the lung function, pulmonary function. And I have found, and we've published a number of studies on pulmonary function after the anterior approaches, and with the minimally invasive technique and thoracoscopic technique and small incisions, we found no impact at all out to 2 years following surgery. In fact, initially there's a decline, and we see that also even with posterior fusion approaches. Initially there's a decline and it comes back up. So I've been very comfortable that we are not doing harm, but that we are actually offering techniques that do have merit and are beneficial to the patients. And the proof is in their activities and their function and their satisfaction scores. When they fill out their questionnaires, they seem to be very happy with their outcomes.
Well, some parents tend to be concerned with respect to the anterior approach in terms of if there are additional revisions that have to be made. Is there kind of a number of times you can't, or a limit to doing the anterior approach before it does impact the lungs?
Yeah, I think every time you do a surgery, whether it's anterior or posterior or anywhere in the body, not even just the spine, there's scarring that occurs, scar tissue forms. And the same thing happens when you go into the chest cavity. And so there can be scarring, and the lung can be affected a little bit by that. But we've seen, at least with a single operation, no issues, as I said, with lung function and pulmonary function. And we haven't really seen problems in the very few revisions that I've had to do, either my own or other doctors' cases that I've revised. Patients seem to do very well. But I would agree that we don't want to be going into the chest cavity time and time and time again. I don't think that's ideal.
Mhm.
And there may be other techniques. There is a newer technique available that allows some non-fusion surgery to be done from a posterior approach, and that there may be some overlap. And I'm happy to discuss that with you.
Absolutely. Well, since you're talking about it, we might as well jump right into that.
Okay, so there's a newer device as well with less track record in the United States. It's really brand new. We're just starting to begin to do cases, and it's called the Apifix device. It's one where we, again, approach from the back, from a posterior approach, and we place 2 or 3 screws, and there's instead of a rod, there's a ratcheting longitudinal device. It's almost like a rod that goes up and down in the spine vertically, and there's a ratchet so that it allows movement and motion, and even permits further correction after the surgery. And the screws fix into the spine, but this ratcheted device doesn't fix to those screws. It attaches to them, but it moves. That connection moves. So the patients have at least some flexibility.
Mhm.
And it also allows for treatment of smaller curves, perhaps, where we worry about overcorrection with a tether procedure. The Apifix, I think, is really nice for smaller curves and in children and adolescents who fail bracing as well.
Mhm.
So that's going to play a role too, and that may also be a preferred treatment for families who prefer not to have their child go through an anterior procedure. So we, in my practice, we present all options side by side. I even have a decision tool that's a PowerPoint slideshow where we show fusion, tether, Apifix, talk about the indications, the differences, the approach, the complication possibilities that might occur, and then allow families to ask questions and sort of try to help them make their decision with as much information as possible.
Absolutely. I guess every procedure has its parameters, so to speak.
Right.
Now with the Apifix, I realized that because you hear about material sciences and that even tethers break, even rods break,
Yes.
and sometimes the shaft of the Apifix, or there might be screw pull out because of so much mobility in that area.
Yes.
I believe Apifix is also, they used to have one screw at top, one at the bottom, and sometimes they double up with longer spans of the shaft, right?
Yes. So now there is the FDA approved device actually has an extender at the top part of it where you place 2 screws and attach to 2 screws at the top, and that's the recommended approach, and 1 screw at the bottom. All devices that move, and even sometimes the fusion device implants, as you mentioned, can break. The good news is that that's not a catastrophic problem. People don't have severe pain generally. They may have some pain initially, but that usually dissipates, and it's not a big problem. They don't have neurological injuries. They don't get paralyzed. They just may have a fatigue of the implant, and they may see it, feel it initially. We may see it on the x-ray or loss of correction. There are different ways that it is picked up, but we can address these problems. With the tether, if the cord breaks eventually, a lot of times nothing needs to be done. The cord just stays there. It is fixed to the screws that are in the vertebral bodies. And a lot of times the correction holds, or there may be just a small amount of loss of correction, but the patient still has good function with flexibility and movement. So it turns out to be okay.
Now, with how many Apifix procedures have you done? I didn't realize.
So far, none. We're going through our institutional review board, which is required through the FDA process, but we hope to get started in August.
Okay.
I've put in thousands and thousands and thousands of pedicle screws, which is the technique that has to be precise, and we use navigation, spinal navigation, which is a kind of a GPS system that develops out of the astronauts' work over the past several decades, which allows us to place the screws precisely and near perfectly. And with that, I think the problems of screw pullout will be really minimal and not of concern. So I look forward to bringing that into my practice as one of the tools that we can offer patients and their families. So.
Most excellent. The more variety and the more innovation, the better, I think.
Yes.
Speaking of vertebral body tethering,
Yes.
When did you first hear about that? And I'm sure that your anterior approach was already in line with that procedure anyway.
That's true. And my anterior work did put me in line to get right into the tethering business, if you will. And I really took my time in entering tethering and offering that to my patients because I was concerned that we wouldn't offer the best option and the results might not be good long-term. So I decided to hold back a little bit, and that's not necessarily my personality. I like to look at new options that offer promise, but this one was one that had me a bit worried and cautious about offering something to adolescent children and then having to do lots of revision surgery. I thought maybe the screws would loosen. I thought there'd be a lot of tether breakages and overcorrections and problems that would just be not an ideal solution. So I made a conscious decision to hold back a little bit. I first heard about the science behind it, the basic science behind it came from animal studies by Ian Stokes, who is a PhD, and he created scoliosis in the tails of rats by applying an external fixator, so pins that went into the tail, and he loaded the tails on one side more than the other, and with that he created a scoliosis. And then, so that was kind of the basis of this concept of growth modulation, which is what tethering has been designed to really do, and we've gone away from that in some patients, and I'm happy to talk about the more mature patients. But for the immature patient, meaning remaining growth exists, it's the growth modulation that allows for correction gradually over time by tethering and holding the spine on one side and allowing further growth on the other side. So we first started hearing about that. I think those early studies were in 1996 and later. And then there were other studies that were done in larger animals to really try to understand the science and see if there would be a case for this. And then I think the first procedure in a patient for tether was done about 15 years ago or so. And that surgeon doesn't even perform the operation anymore. But the majority of tether procedures really have been done in the last several years now. And maybe there's been 2,000 done in the world, maybe a little more than that. I've been performing this procedure for the last 5 years. There was a very minimal learning curve for me because I had done these approaches 25 years ago for quite a number of years. And so, of course, we were very cautious and careful and carefully selected the patients. And we started off very slowly, but now I do somewhere around 120 of these procedures every year.
Okay. You recall how many total you've done over the 5 years?
Yeah, nearly 320 cases now.
Okay.
So, and you know, again, the last few years we've been much busier than when we first started off and really started very slowly.
Okay.
Yeah.
Even with the FDA approval for
Yes.
For the tethering or the tether from Zimmer, there are still quite a number of spine surgeons who are pretty cautious about tethering and waiting for more long-term data. What do you see, firsthand that they don't particularly see right now?
I think there's genuine caution amongst pediatric orthopedic surgeons who treat children. I think they really are conservative by nature and want to make sure they don't offer patients something that will do harm. And that is our oath as physicians and surgeons, is first do no harm. So I think some of the caution is in that. Some of it is that, especially the more experienced surgeons who have very busy practices, it's not easy to go through a learning curve when you're in your 40s and 50s. It's easier when you're younger and starting off. It's just as it's difficult to learn a new language or to pick up a new a sport or when you're in your middle age. So I think some of it is that, and the fact that many of the spine surgeons haven't been trained in these approaches. So a lot of it is that as well. I suspect that as we teach more and more of our fellows and residents the techniques, there'll begin to be more and more surgeons who are comfortable with it. But for now, I think there'll be most of the procedures would be concentrated at very busy spine centers where this is done routinely. So I think the future will be that there will be more and more surgeons who participate, but I think it's probably irresponsible to have many surgeons doing only a few cases each year, because you want the most experienced surgeons to do this. What I see is patients who recover very quickly from surgery compared to the fusion. We get them into a swimming pool at 3.5 or 4 weeks once the incisions are largely sealed, and we get them into walk-in and do kickboard in the pool and even some gentle breaststroke. At 6 weeks, we get them started with physical therapy, and they can start playing their sport, depending on the sport. But they start, playing basketball, playing hockey or field hockey, skating on ice, swimming in the pool, playing tennis, golf, and many other sports. And so dancing, for sure. We have a lot of dancers and even gymnasts. So we see a really rapid return to function and activity and fast recovery that is definitely different than what we've seen over my 25 years of practice for fusion patients. So that has made me very enthusiastic about this procedure. Now, there are some cautions. There's some caveats to that. And we tell all the families this, depending on how much growth the patient has, there are different issues. So a younger child with much more growth has the risk of overcorrection, where we might have to at some point intervene and either cut the cord, remove the cord, loosen the cord, depending on how much overcorrection is occurring, where they correct into the opposite direction. If there's a little bit of overcorrection, that's okay, as long as they reach the end of growth and it's there, it's not a problem. But if we're seeing progressive overcorrection and they're still growing, then we would intervene. The other part is, and I operate on more mature patients, skeletally mature, who have little, and in some cases, no growth. And I've even operated on some adults, which is very controversial, but we've had actually some amazing results in the adult population. And I really think this is going to have a role for our adult patients in the future. And so I quietly have been doing this with long, lengthy discussions, many discussions with each adult patient before we embark on this. And usually they seek me out. And it is my duty as a surgeon and as a physician and a compassionate doctor to collect the data to make sure that we have long-term follow-up as long-term as possible. And that just takes patience and diligence. And we're going to, study these patients and follow them for as long as possible and then report our results. So I think the older patient and the patient who has less growth, we're more concerned about loss of correction if and when a tether might break, because they didn't have that growth modulation where maybe a wedged vertebra could square off with this growth modulation. But they may have remodeling of their spine, and we don't know that yet. We have to study that as well, and that takes enough patience and enough time to do it. So patients meaning people that we've operated on, patients as well, being steadfast and patient and wait for the results, and then we'll report it. But I do think remodeling likely occurs if we can hold the adult or the mature spine as straight as possible for years. And what we do is for lumbar curves especially, but also for some thoracic curves, in my more mature patients, I'll place 2 cords. So 2 rows of screws and 2 cords, and that will last a lot longer. And I've never seen a breakage with a double cord so far. And we've been doing that for a few years now.
Even in the lumbar spine, that's pretty impressive.
Yes, even in the lumbar. Single cords, that's another story, but with double cords, I haven't seen a breakage yet.
Okay. In general, do you recall how many mature spines you've tethered?
I've done a lot. I would say probably 30 or 40% of my total.
Okay.
Yeah.
And
most of them are adolescents, you know, even
Sure.
14, 15-year-olds, but they're more mature. Yeah, some up to 40%.
Okay. I guess because since they're late adolescents and even
Yes.
going into 16, 17, you know, even early 20s type of thing, there's still some remodeling occurring more than you would expect, for instance, in a 40 or 50-year-old.
Right.
And that's what you're kind of shooting for.
I think that is true. The hope is, and I believe that is a correct statement, that a younger patient, even in their early 20s, will have more potential for remodeling than an older patient. But bones remodel even in adults. And we see arthritis, the process of arthritis and degenerative disc disease in our middle-aged adults who, over time, they may have a curve and they develop bone spurs. That is a form of remodeling of the bone due to stresses. It reacts to stresses. I think we'll potentially see something like that even in the adult patient. And it's going to be a factor of how straight we make the spine at the time of surgery, how well and how long we hold it for the years, you know, prospectively going forward. And if we do that, I think we'll see some of them, or many of them, hopefully with a good long-term outcome. But it's very controversial. I even say to them, it's experimental. It is a journey, and it's kind of being on the frontier. And it's not for everybody, but it's generally the adults that come to me. I have one patient in mind who came to me from Chicago, and she's by now 57. She was 55 when I operated on her, and she had tremendous pain. She was an avid, she liked to work out. She would work out every day and was in great shape, but she had to stop for months. She wasn't able to do that anymore because of low back pain. And it affected her life. It affected her whole quality of life. And she had a deformity, which was unsightly to her. It bothered her a lot. She's an attorney. And she and I spent a lot of time in advance. And I told her fusion is the standard operation. It works well. You know, the drawback is it eliminates motion in the areas that are fused. And some people will develop problems above or below a fusion. She really didn't want a fusion. So we did a double cord, a double tether, and she's now almost 2 years out, and she has, and we're in correspondence by email, she has zero pain, actually. She said, I have a little bit of hip pain, but that's from a labral tear in her hip. And she works out all the time, and she's, you know, she loves the improvement in her body shape. And so it's remarkable. And I've seen that in a few patients. So I think time will tell. We have to be very cautious. We have to be open and honest with patients and tell them that we don't have long-term follow-up. But I think there may be a role for this in the future, especially as we gather more data.
I hope so, for sure, because you know, an alternative to fusion, if the research backs it up, would be amazing.
Yes.
Now, in terms of your mature patients, what kind of parameters are you looking for? You know, limited wedging, I assume.
Yes.
Some flexibility.
Yes. So I think the very, very large curves are not ideal for that, because we want a large, very large curve, especially if it's not flexible and if there's a lot of wedging. It's going to be hard to win that battle for the patient. So we want to be able to have a curve that we can make almost straight or as close to that as possible, and where there's the remodeling potential. If they're very wedged and very have a large residual curve at the end, the cord will probably not last very long, I think, in those patients. And that will have to be looked at in the future. Sometimes and this is true for my still growing immature patients, we do a hybrid where the thoracic curve, the ribbed portion of the spine is very, very severe. And maybe the curve is 80 or 90 degrees or more, 100 degrees in some cases. And there's a lumbar curve below that, that may be in the 50s or 60s or even in the 70s. And so in those patients, I've offered fusion for the upper part, for the thoracic curve, and we've tethered below, and I've been very happy with that. My patients, more importantly, have been very happy with it, and they've done super well. And I think that gives them, and I feel that I can offer them something that has more predictability and will give them the kind of correction of the curve and of their body shape kind of asymmetries that they would like. So it's more reliable in that effect. So we have to be very careful about who we choose and who we offer this procedure to.
Right, because I assume you do that for more mature spines or severe spines and immature spines as well.
Even in severe curves for immature spines, because you know, I know that sometimes I have been convinced and talked into doing a tether where, in retrospect, I wish that I really steered the families toward a fusion. In some cases, I know they've gone elsewhere, but I don't feel that it's responsible to take on a very, very severe curve when it's likely to fail. So I think there are some bigger curves that we've done, and they've done very well, but they have to be carefully selected. And that's the patient who has a flexible spine and whom we have a fair amount of growth remaining. The more mature patients, they have to really be able to correct very well.
Right from the start, right from the get-go.
Yes.
Because of lack of growth modulation, for sure.
Correct.
Now, with the parameters of, we talked a little bit about your parameters for mature tethering. What are your perfect parameters for traditional VBT in an immature spine?
Yes. So for the younger patient who has a lot more growth left than a slightly older patient who has some growth left, the younger patient, we have to be careful about timing. If we address their curve, and if it's especially a smaller curve, and we do the surgery too soon, they're going to overcorrect. So we look at the various growth plates. We look at a hand X-ray, the Sanders score, and we look at the triradiate cartilages, which are at the hip. If they're open still, and the patient has a 40-degree or 45-degree curve, we may get into trouble with that. So we may delay, even if it means bracing that child for a little longer and holding things just until they're slightly more mature, where we think we're going to get some further correction, but land in the sweet spot as opposed to having to have another operation for overcorrection. The older, slightly older adolescent, we can take a smaller curve and not worry so much about overcorrection because their growth is slowing down. They still remodel or have growth modulation, but they're going to be landing in the sweet spot more predictably, I think. So those are, I think, easier to address. So I have some patients who have curves that are 70 or 75 degrees, but were very young and had a lot of growth, and they have done really well in my practice and in my hands. But you have to, you know, there's some uncertainty to this. Fusion, we put the screws in, we place the rod in, and we fuse, and we know the spine is going to stay just where we put it. Here, there's some reliance on judgment and timing, and also technique, where we place the screws, how we place the cord, how much correction and tension on the cord we apply at the time of surgery. All of those factors have to be taken into account. And I think we're going to develop techniques and tools that allow us to be to predict the outcomes in patients better. So that will come with time, and those sorts of things are being developed over time as well. So for the younger patient, maybe slightly larger curves or larger curves, and maybe delaying surgery if needed. The older patients, we can address smaller curves and larger but flexible curves very nicely.
So if you're going to quantify that in terms of Sanders score,
yeah,
in terms of maturity, what would you?
So I think there's Sanders 3 or 4 and lower. I think, you know, a Sanders 1 and 2, there's a lot of time left. And so those may be, I think 3 and 4 probably ideal for many patients. 5 and 6, we can see some remodeling. 7 and 8, there's going to be very little growth modulation. 8 is essentially a mature spine completely. 7 is pretty close. But 3 is where their growth spurt occurs generally. So Sanders 3. So 3 and 4, and then above that is the more mature spine. 1 and 2 is going to be a lot less predictable. They haven't hit their growth spurt at 2 yet, but they are about to. And so that's where, time will tell for those patients.
Sure. Because of course, with parents wanting to maintain flexibility in their spine, and if they miss that traditional VBT window, 3, 4, maybe 5, unlikely
Yes.
though. Is that what kind of led you into mature spine tethering in the first place?
Yes. First of all, by the way, I have also operated on even younger children who are Sanders 1 even, because they have very severe curves that are getting worse. It's the early onset group of scoliosis patients I've operated on as young as 6 years of age, with the understanding with the parents that there's a high likelihood of having a second operation for overcorrection, or maybe even curves adding on that we didn't expect. But their desire is to avoid fusion, and so the only way to do that is to guide the growth through tethering, and hoping that we can control the spine as well as possible, and then know that we would likely address overcorrection possibly in the future. In terms of the older and the more mature patients, yes, a lot of them miss the traditional time points for performing VBT, and the families really felt strongly that they wanted to preserve their child's, usually daughters, but sometimes their sons, flexibility and function. They may be highly athletic and involved in swimming and dance and sports and gymnastics that require much flexibility. And also they're concerned about the future. So some of the parents had a fusion themselves in the past 20, 30 years in their past, and they don't like the way it feels. And others may have had a fusion and feel fine about it, but they may also want something different for their child. So I was I tiptoed into doing those cases, but eventually we found that the patients were doing so well, and I think especially with the double cords in the lumbar spine, we're seeing really excellent results, and no limitations in activities. So, which is different from lumbar fusions, where sometimes the patients have limitations and they may have back pain, and they then, when they present as adults, they have disc degeneration and back pain below the fusion. And in my practice, I guess what also helped me is I don't treat just children. I also treat babies on up to people in their 70s and even older. I treat adult patients too. So I see my own patients that I fused 25 years ago, and I see other surgeons' patients, and they come in with pain. Now, that doesn't mean every patient that has a fusion will have a problem, but the ones I see do have problems. And so maybe this will be an opportunity to avoid some of those long-term problems. And as an adult surgeon as well, that's really important to me. I want to see the long-term outcomes be, impacted positively.
Sure. Because I know relatively, double tethering is relatively new in terms of trying to reduce breakage rates, especially in the lumbar spine, where there's so much flexibility. I believe there's some literature indicating that there is some reduction in flexibility with the doubles because you're kind of doubling the resistance, right?
Yes.
But you've seen a little bit more flexibility than lack of?
I haven't seen much in terms of lack of. What if you have a tether, let's say on the left side in the lumbar, the patient will have a harder time, more difficult time bending to the right. But they'll be able to bend to the left, flex forward, extend, and rotate. And I personally have not seen, clinically at least, any problems. There's going to be some research looking at range of motion following these procedures, and our center is involved in that as well, where we'll be able to quantify it better. But from a clinical standpoint and from the patient's standpoint in terms of their activities, I have not seen a significant impact.
Okay, that's terrific.
Yeah.
I'd like to go on to another controversial topic, which is disc release.
Yes. Yeah.
All right, because you have the two spectrums, not doing any disc release and doing,
yes,
you know, even an anterior release with a disc release type of thing. Where do you kind of fall on the spectrum?
I don't believe we should be automatically doing disc releases on patients because, you know, when you cut the disc and you impact the patient's innate anatomy, you're injuring the disc. And so I don't want to do that routinely at all, but I think there are some patients who have larger curves, and with a disc release, we can make those curves more flexible and really get a very excellent correction. We almost always do that in the thoracic spine, very rarely in the lumbar spine. You know, reason I feel comfortable doing a disc release is because as a surgeon who's done many adult surgeries and many discectomy operations for sciatica, for a slipped disc, we go into the disc, we sometimes will make a cut in the disc and we remove the inside of the disc, and those patients do extremely well. And that's in the lumbar spine where there's so much flexibility and motion, and most of those patients don't have long-term problems. So in the thoracic spine where there's much less motion, there's still motion, but less than there is and less forces than on the lumbar spine, I feel that it's very reasonable. And we haven't seen problems, knock on wood, we haven't seen problems with our patients that have had disc releases. And again, these are for patients with larger curves where we limit it to the area of the spine that doesn't correct fully on the bending x-ray. So I feel that it plays a role. You know, long-term follow-up is going to be the key, as we say time and time again, long-term follow-up. Tether procedures don't preclude something else being done in the future, including a fusion. And the hope is that patients will never need a second operation. Nobody wants a first operation for their child or for themselves, but we hope that we'll see these hold. And I think maybe there'll be some scarring of the discs themselves, just like when you cut your finger, there's a scar that forms, and the finger and the skin still functions and works fine. And the scar may decrease motion very little bit, but it also might provide some stability to that area, which would be a good thing in holding the curve. So I think for carefully selected patients with a full discussion, I think it's okay.
Now, when you do a disc release, do you cut the annulus? Do you remove the nucleus, or do you, is there?
So we cut the annulus, the outside portion of the disc, to increase flexibility, but we do also remove a little bit of the inner nucleus, because a lot of times the nucleus will just come out as we make that cut in the annulus, and we just remove the loose portions of it, and also helps to close the spine and close the curve to get correction. So we do remove that, but we don't take the end plates where the cartilage is, because if you take the end plates off of the vertebra of the bones of the spine, that creates a fusion. So we're careful to leave the cartilage and just remove the inner portion, and especially focus on the annulus.
Okay, because I know in some of the anterior fusions, especially for severe curves, they used to do release the anterior longitudinal ligament as well. So
yes.
Do you do that for severe curves, or not really?
No, for severe, so for fusions, even if I'm doing a fusion from a posterior approach from the back, and I have a patient with a very severe curve, like a girl that I operated on 2 weeks ago. I operated on her and her brother in the same week. She had a very severe thoracic curve and a moderately severe lumbar curve. So we did a disc release, including cutting the anterior longitudinal ligament. And we do that with her lying prone through 2 small incisions using a scope, and takes about an hour and very little blood loss. And it helped make the spine more flexible. And then I did a fusion for her thoracic curve, and then we turned her on her side and we did the tether for the lumbar curvature, and she's done very well. So there is a role, I think, certainly in my practice, to use those techniques even in fusion. And when we do a disc release, we also cut the anterior longitudinal ligament in addition to the annulus to help with that flexibility.
Is disc release more or less for a mature curve, or you try to stay away from that from immature curves?
I mostly for mature, but if I have a child who may be slowing in their growth, or the apex is really stiff, yes, and we're not getting it straight enough, I think the likelihood that growth modulation will take hold is not very good, because the concave, the narrower side of the spine, the discs are being loaded and the growth is not permitted, so they can't growth modulate. So I think in some immature spines, for the patient, we will do a disc release at 2 or 3 segments as needed.
Okay. Is it true that once the disc is removed, that bone growth modulation cannot occur?
It's only true if the whole disc is removed, including the cartilaginous end plate.
Okay.
So we're very careful to not violate the cartilage and the end plate, because then they will fuse, and then there's no growth modulation. You know, there will likely be, and I'm involved in the development of the first FDA-approved implant, and the only one so far, which is, as you mentioned, the Tether. So far, there are no other ones in the United States, at least, that are FDA approved. And we're going to embark on another project, the next generation of this device. I see in the future that we would potentially, for larger curves, have the ability to fuse the apex, but tether above and below it, and all through the anterior approach, so doing it all together. And I think that would allow more patients to have access to this a technique with less fusion. So a little fusion is better than a lot of fusion, I think, and hopefully that would pan out long term.
Oh, so that is the next phase. So we have a little scoop here then.
Yeah, I think well, at least that's my opinion, and that's how I see it playing out. Yes.
Okay. So you do a specific fusion at maybe 2 segments, then you tether above and below.
Yes, I think that could be very effective.
Okay.
Yes.
Pretty fascinating. And that was my next question about Zimmer Biomet. They seem to be very, very focused on the training of new surgeons, because they have to kind of pass a bit of a certification course with them.
Yes.
Have you been involved in that as well in terms of training new surgeons in the process?
I have been, and I take it as a very important responsibility, because I have my own patients, but we have collectively as doctors and surgeons, patients all over the world. And we want this to be done well. We want this to be this procedure to be done safely. And we don't want surgeons who have the best intentions to go off and not be experienced and make mistakes and have problems. And I think, so it's my duty, it's the duty of Zimmer Biomet, the company, and other surgeons involved, to really teach the technique, to mentor surgeons, to guide the process, to make sure patients are having the safest possible operation with the best possible outcomes. So I'm very much involved. We've been doing Zoom teaching for now, but we also have done cadaver labs, and there are new synthetic models that we can use that don't require a cadaver. And we'll be doing that. Once this pandemic passes, we'll be in-person teaching. And, we also speak to surgeons about their cases and about the indications and who's the best ideal candidate and who's not such a good candidate, and et cetera, et cetera. So there'll be a lot of that sort of interaction.
Just 2 quick questions since we're on the Tether. Do you have any news on any stronger tethers coming out in the near future?
No news, and that's, I think, really important, is that we figure out a super duper tether, one that's going to last forever. That sounds like a nice little rhyme there. A super duper tether that will last forever would be ideal. I think we'd be able to, you know, avoid some of the loss of correction that can occur with breakage. We might be able to avoid double rows of screws and 2 cords in some patients. So I think that would be a big plus, and that's going to take work with the company. It's going to take work with scientists and engineers to figure out if there are materials that are, number one, safe in the human body, and number two, will last longer than what we have now. So work to be done in that area for sure.
Okay. My final question is with mature spines,
Yes.
since you're on the forefront of tethering, do you see any advances in technology that are going to help specifically with mature spines? Of course, stronger tethers, but is there anything else that might be coming in the future?
I think a big part of it is the stronger tethers. I think the double rows of screws and anchors, improved anchors into the spine. So we use staples that anchor into the spine. And so if we can improve the anchors along with improved cords, I think that will help a lot. I think the concept of combining a fusion with a tether in some of the adults where they have quite a lot of arthritis in certain segments, tethering there might be unpredictable. So maybe, again, tools and implants that allow us to do both a fusion and a tether right adjacent to one another, I think are some advancements that the future will hold.
Sorry, I have to ask you one final question.
Sure.
Now, with severe curves for mature spines where there's significant wedging, so typically for those individuals, you'd straighten as much as possible, then you'd fuse it. Do you have any opinion on doing any kind of osteotomies at different levels in terms of trying to correct it that way and thereby perhaps sparing the discs?
Yeah, that's very advanced technique. The problem with that is, you know, it's one thing to do it in a cadaver or in a model where the predictability is not important about the future. So, but I just worry about if we get too fancy, we're going to end up with complications and, you know, osteotomies falling apart. But it has been done, it has been tried in immature spines, and particularly patients who don't have the ability to walk. So there's less downside for those patients. So I think, is it possible? Perhaps. Is it the best approach? I'm not so sure. I don't think I would want my family member to be the first to sign up for one of those procedures. And my litmus test is if it's not good enough for me or my family member, I wouldn't offer that up to a patient. Sometimes families come to me with their own ideas of what they would like and what they're hoping for. And I would say that it's a conversation, it's a two-way street. We try to come up with the best solution for the individual patient. It's very individualized. But I think when we get too fancy, that's when we run into problems.
Okay. Thank you, Dr. Lonner. It was a pleasure. Again, I learned so much when I speak to you and your colleagues, and I appreciate you taking the time to educate us even more.
Thank you so much, Dr. Lee, for putting together this series and for getting information from surgeons. And I think it's hopefully helpful for the public and for individuals with scoliosis and their families. So thank you very much. I enjoyed spending time with you today.
And likewise. Thank you very much. Have a great day.
You too. Take care.